welcome back to the channel. My name's Holly and I'm a third-year trainee clinical psychologist. Today we're going to be talking all about risk assessment in clinical psychology. And I'm going to go through the aims in a minute, but firstly I just want to caveat, if you're dealing with a risk situation with a client, with someone personal, particularly in a clinical client situation, speak to your supervisor. Always speak to a supervisor, someone that can advise you, someone that has that clinical responsibility to your client. Make sure that you're sharing that risk. So hopefully this will give you some general advice around risk assessment and risk management, but make sure that you are always seeking support from somebody that's more qualified if you need that support. Let's get into it. So risk assessment in clinical psychology is usually quite a big topic. The aims of today, we are going to think about why risk assessment is important in clinical psychology, what some of those risks we want to consider are, how to do a risk assessment, what risk management is, and also how does this apply to me. We're going to be going through some resources and also some questions from you as well. So why is risk assessment important in psychology? Well, psychologists work in multidisciplinary teams. So teams where there could be a nurse, a doctor, physiotherapist, dietitians, all sorts of different disciplines. Psychology is a discipline, nursing, medicine, same thing. They're all disciplines and you're working together to support people. And psychologists often lead on the risk assessment stuff, sometimes in partnership with psychiatry or medicine or other disciplines, but often psychologists do, it's part of their role within the team is to think about risk. We work with distressed people and in systems where risk is often present. So it's really important to have an understanding of what risks are, particularly as in psychology, we are often looked to kind of help manage some of those risks and help identify some of those risks a lot of the time. We also work in positions of trust, actually, where people may disclose things that they never have done before. Could be criminal acts, could be risky situations that they've experienced, and having an understanding of how to manage a risk when someone has disclosed something to you is very important. We all have a duty of care as healthcare professionals to make sure that we are safeguarding the people that we work with and the people around them. So understanding what to do, what the protocols, the legal protocols are for us in a risk situation, and also how to make sure that our clients and the people around them are as safe as they can be. And we are trained in psychology to be curious and to hold quite a lot of information in mind while we're assessing and formulating the people that we support. And risk is just another factor of that. We need to think about the things that are important in risk. So let's think of some risk examples then to try and make some sense of this. In psychological risks, we have firstly suicidal ideation, which is often we might say somebody has suicidal ideation if they are having suicidal thoughts, whether they're fleeting or persistent, but it's kind of having thoughts of suicide or possibly thinking that suicide might be an answer for them, a solution. Then we have deliberate self-harm, fairly self-explanatory, but it's where somebody might harm themselves in a deliberate way. So that could be through cutting, that could be through burning themselves, it could be through punching things, it could be through scratching themselves. There are a lot of different ways that people can deliberately self-harm. Then we have distress. Now distress, it is sort of a risk, I suppose. Often the people that we see are distressed, but where distress really is a risk is in context with the other situations. So if somebody, we'll go through it a little bit more when we get through the different types of risk, but let's say somebody is street homeless and they, it's really cold one night. Well, they're going to be more distressed, which means that they're more likely to engage in other risky behaviours, whether it's going somewhere really unsafe for a night to make sure that they can get in warm somewhere. But that distress is a driver for some of that risky behaviour. So that's why we think of it as a risk. And also, when we're doing work with people, therapy work, distress can be a kind of byproduct of that. And in therapy, we want to try and help contain that distress and help people negotiate with it and manage it. But distress is a risk of doing any kind of therapy. So it's something to consider. Then we also have insight or awareness. And I guess this is somewhat controversial. So the lack of insight or awareness really is the risk, not having insight and awareness. So that is where people maybe aren't aware of some of the dangerous things that they're doing. For example, if we think of the street homeless example, they may not really see that as being a risk because actually they don't have much other choice. So if they have to do that, so they may think, it'll be fine, but they're completely disregarding the risks. And that's probably a coping mechanism of having to cope with that situation. You don't want to stare the risks in the face, but that's perhaps a lack of insight into actually how risky that behaviour is. And there are lots of other examples. Trauma. Trauma is a big psychological risk, and that is risk of experiencing new trauma again. So it could be when you're doing trauma work with somebody, we want to make sure we're not at risk of re-traumatizing them. We want to help them through the trauma. And it also could be historical trauma. So that is a risk factor as well for possibly possibly experiencing future trauma. And it depends on how they've recovered from that trauma, if they have, and whether they've processed it. We also have symptom severity to consider. So yes, we can look into diagnostic labels, things like obsessive compulsive disorder, OCD, but we can also look at distress as a symptom as well. So really we're looking at how severe those symptoms are. Are those symptoms so severe that somebody can't get out of bed because they're so depressed? Is it that they actually they just can't function at all? They can't go to work. They can't look after the people they need to look after. Can they even look after themselves? Because those symptoms are so severe. So that is an example of some psychological risks that we want to be considering in psychology. We also have physical risks. And just because it doesn't have the word psychology in it does not mean that as psychologists we aren't looking at these, because we are. It's really, really important. Again, coming back to that duty of care to safeguard the people that we look after. So physical risks, we've got things like violence and abuse, all different types of abuse. It can be emotional, physical, verbal, sexual abuse. All types of abuse are very important, financial abuse. And we have exploitation. Again, we need to be thinking, is someone being exploited? And this could be an adult, it could be a child, it could be anybody that we see. So we need to make sure that they are not at risk of exploitation in any way. Issues from health conditions. This can be really important in psychology, and we may not think so, but actually if somebody is diabetic and is perhaps so distressed by their diabetes and by the whole management process, or so fearful of injections that they are not going to be able to be adherent to their treatment, that can lead to serious health conditions. It can lead to amputation, it can lead to blindness. They're really serious risks that we need to consider. So we're not just thinking about what is the risk to somebody's psychological safety, but also their physical safety. We also have medication side effects. This is usually one that will be thought about by the medical colleagues that we have and someone's GP, but it's important for us to think about that. So if we are doing an assessment or therapy with somebody and they come in and they seem very sedated, absolutely we're going to be thinking about substance misuse as well, but we need to be thinking about what medications they're on, because it might be that they are over sedated and they haven't reported to the GP, or they haven't even noticed that they might just feel tired. So again, healthcare professional, we have that responsibility to people. So it's important to have those conversations about what side effects are to medication, but we need to do that within the boundaries of our competence and knowledge. So we are not medical doctors. Usually psychologists aren't medical doctors, have not had training in medicine. So we need to refer to GPs. And if someone has a question about medication side effects, we can take the information and we can direct them to the GP or to, more suitably qualified colleagues. What we won't do is say, oh yes, that's a normal side effect. We need to check that information first. Then we have systemic risks. So these are more kind of social risks, I guess, that we need to think about. Things like interpersonal relationship difficulties and conflicts. So if someone's in an abusive relationship, or if somebody has a perhaps strained relationship with somebody, or if there are dynamics there that might be difficult and might put people at risk of distress and other things, they are important things to consider in a full risk assessment. Accommodation, again, where are we in the system? Are we housed? Who are we housed with? Is it a safe space? Are we at risk of losing that accommodation? Is the accommodation secure? Is it safe in terms of not just your personal safety, but is it habitable? Is there lots of black mold everywhere that's going to lead to physical health risks? Think about those things, accommodation-wise, is very important. Employment, again, so are they employed? Are they at risk of losing their job? What sort of stress does that bring? Do they enjoy their job? Is it too stressful? Is it not enough work? Thinking about how their employment might be affecting their risk factors is important. Then we have things, far broader things like discrimination, racism, prejudice, targeting, those sorts of things we do definitely need to consider. So a lot of this risk assessment work that I've done has been in substance misuse, because it's such a prevalent thing that we have to do. It's such a priority in substance misuse, is doing risk assessments. And a lot of the time we would be working with people who are street homeless, and they might be quite well known in the town, and they can sometimes be targeted by different people, if someone or other people that might use substances. So let's say everyone knows that you get your universal credit on a Tuesday and you like to take out in cash. Well, then everyone, there might be people that target you on a Tuesday and take your money from you. So then you've got no money to do anything for the rest of the week, which means that you end up having to go into crime, things like that. And there's also, we cannot ignore the impact of generational trauma and institutional racism that exists. Those things are really important, and it's not just on a personal level when we're doing systemic risks. We need to be thinking, okay, is the team treating this person fairly? Are there any prejudices here actually that maybe are probably unspoken? If not, just dealing with that sort of level of thinking. And as psychologists, we're being trained to be leaders in teams. And kind of team dynamics and how teams communicate is part of that. So yes, we might feel like we're a little bit away from the individual person that's sitting in front of us that we might be risk assessing, but actually it's really important to think about those wider factors, because if a person is experiencing prejudice or discrimination or racism from a service that is supposed to help them, what are they going to be experiencing out in the general world? It's really important to think of those factors. So in terms of risk assessment then, what do we need to do? We need to think about what the risks are. We need a really comprehensive understanding of what all of those risks are for somebody. And the examples of risks that I gave are just examples. There are so many more things that you need to consider, and it will depend particularly on the service that you're in, the location you're in, the client's presentation. It will depend on a lot of things. What the risks are, as I say, very important. We need to know exactly what we're dealing with. That could be risks to self, deliberate self-harm, suicide, risks to others, violence, aggression, etc. Risks from others, again, violence, abuse, exploitation, and other risks by accidental risks, physical health risks. We also need to know what the severity of the risk is and what the likelihood of the risk happening is. So when we're thinking about severity, if we're thinking, okay, let's take an example of somebody that has a history of deliberate self-harm through cutting. Let's take an example there. Actually, we need to think about how severe that cutting can be at times. Is it that they have needed surgery to correct that, or is it that it's very kind of superficial, minimal scarring and damage that's done? What is the severity? Is there a chance that they actually could do some serious damage to themselves? Then we need to think about the likelihood. So what's the likelihood of this happening? That's a difficult one to assess. So what you want to do really is think about the history of somebody. So in this self-harm example, what's someone's history? Have they had a history of this? When was the most recent time they did it? Why did they do it? What happened before? What happened afterwards? Did they seek care? Did they go and see somebody to dress their wounds or to treat them? Did they clean them themselves? Did they look after them? What implement did they use? All those sorts of things are really important. And also when you're doing risk assessment, it kind of comes up more in risk management, I guess. They're all one process. But you want to be thinking the likelihood is also around the risk management. So if you've managed that risk, the likelihood should reduce, but it's important to know what that likelihood is. Again, in substance misuse, if someone comes in and they've fallen off of their methadone prescription, the likelihood of them using heroin is huge. They're going to do that because their body is telling them that's what they need. So that is absolutely, that's a really high likelihood. And the likelihood reduces when someone is on a prescription and is titrated to the right dose for them because they don't feel the cravings to use anymore, is the theory. So that's a little bit about likelihood. Means. This is not averages, talking about means. So again, with the substance misuse example, let's say, what means do they have? Do they have money to be able to buy drugs? Do they usually turn to sex work to fund their drugs? Do they turn to crime to fund their drugs? How able are they to get access to this? Are they housed in a suitable place where nobody's using drugs, or are they in an environment where lots of people are using lots of substances and it's very, very hard? What access do they have to this risk is effectively what we're thinking about. So if you have a history of somebody that may have taken an overdose, you need to think about, well, what access do they have to the overdose medications again? Is it paracetamol? Well, we've all got access to that. We can all go to shops. Or can they? Are they housebound? Are they unable to go out? It's just thinking about how, again, it kind of helps with likelihood, is what are their means to do this? If someone threatens that they're going to shoot themselves, do they have access to a gun? How would they access a gun? Some people in farming communities have guns, or abroad they might have guns. So it's very important to know about this stuff. I'm going to go through an example now. This is not a real case. I just want to highlight this is just a kind of composite based on a lot of examples of people that I worked with when I worked in substance misuse. And this is a risk assessment example. This is a fairly, it can be distressing. So just bear in mind. If it is, that's okay. You can skip through. You can skip past this. So the case example is a male who's age 35. They're using heroin, crack cocaine, cannabis, alcohol, and tobacco. They are street homeless and they're injecting into their groin. So what we're looking at here are the risks to self. So heroin and crack cocaine use, injecting. So there's a risk of accidental overdose there. There's a risk of infection. There's a risk of bloodborne viruses. Because we're injecting into the groin as well, there's a risk that actually that could lead to... so if you're injecting into your arm or your leg, then that limb can be removed. It can be amputated if a problem developed with it. But if you're going into the groin, it's very, very hard to amputate. So there's a lot of risk there of infection. Mixed substances, there's a heightened risk of accidental overdose and a physical health decline as well, because that's a lot of different things going into the body and can have a serious impact. Being street homeless, risk to hygiene, cleanliness, risk of infection, risk of being vulnerable to people. Homeless people have a lot of abuse a lot of the time, so that's very difficult. And not just risk due to hygiene and cleanliness, but also temperature, weather, not being able to get dry, not having anywhere comfortable to sleep, not sleeping, all of those things. Risk of financial hardship and poverty. Using that amount of substances costs a lot of money. So, people that use substances usually don't have loads and loads of money if they're street homeless, that all their money will go on that. So how are they affording it? So they may be turning to crime or running for some gangs. It could be a range of things. So it's important to think about that. In terms of mental health risks, there has definitely been some deliberate self-harm. There's been some suicidal ideation to consider as well. So they're the mental health risks. There aren't any diagnoses, though. Physical health, risk to heart, risk to lungs, but because of taking all these things, risk to being homeless and not being able to wash and clean yourself properly, risk of injections and infections. And there's also social isolation and loneliness, because taking drugs and drinking alcohol to this extent is really lonely a lot of the time. So they are some of the risks to self to consider. Risk from others, as I've said, risk of financial exploitation due to multiple drug addictions. So lots of dealers might offer drugs for free, but then you owe them something, so then you might end up running drugs or stealing things or beating people up, or you're indebted to them, and that's really dangerous. That is exploitation. Street homeless, again, risk of violence from others. Risk to others, so there is a risk of engagement in criminal activity to fund drug and alcohol use, and there's a risk to the general public to consider. There's a risk of violence to others, because there has been a history of that in this case, and there's safeguarding risks as well. So severity-wise, we're looking at consequences actually could be fatal or very severe. Overdose, infection, bloodborne viruses, they are severe. The impact on physical and mental health could be really severe as well. And recovery is really difficult. And it limits life opportunities, and it's very severe, a lot of what's happening for this chap. In the means, he has access to substances that could kill him, actually, using all these substances together. Heroin is a depressant, cannabis is a depressant, alcohol is a depressant, all of those depressants going in alongside the crack cocaine, which is an upper. That's very difficult for the body to understand and manage, but just taking a little bit too much, or taking an amount of heroin that's got fentanyl in, which is a very strong synthetic opiate, highly, he does have means to be able to, really hurt himself. And likelihood, with this level of use, there is a high likelihood that there's an accidental overdose happening at some point. There's a highly likely to experience significant physical health complications, and highly likely to experience trauma and have mental health issues. So this is quite a high risk example, and services, someone like this will probably be involved in lots of different agencies, possibly probation, possibly police, definitely GP, you'd hope, and possibly some other medical services, but usually a drug service as well, hopefully. Sometimes adult safeguarding, social care as well. So that's a very high risk example. But in terms of risk management, what you want to be doing is consider each risk, the severity and the likelihood, and suggestions to reduce that risk. And ideally, when you're doing risk management, it's not something you're doing on your own. You're talking to the client about it. You're saying, look, these are some of the risks that I think are going on right now. It'd be really good if we could make a plan together as how we can reduce some of that risk. Sometimes people won't be into it, sometimes they will. And it's about your relationship with that person, really, and your ability to propose that in a non-judgmental way, in a very collaborative, let's do this together, I'm here to help you sort of way. And it may help to consider how risks interact with each other. So like I said, it's not just heroin use, crack cocaine use, alcohol use. It's actually they are all risky things to do, but when they're done together, it's an even bigger risk. So how those things interact with each other. For example, like I said, so drinking alcohol and using heroin, it all heightens the risk. And another really important thing is you may not be able to eliminate the risk. Have a look at the case example. There's lots of reasons why this person may be using the substances that they are. And it usually will take a lot of input from lots of different people to be able to help this person. But steps can be taken to reduce the risk, and just perhaps not eliminating it. And that can sometimes be something as psychologists we will help the team understand, because we need to know about the risk. It's very important that we know about it, but sometimes we cannot eliminate the risk because people are going to do what they're going to do. But so what we can do is just be aware of the risk, make a plan to try and reduce that risk. And to do that is considering internal and external resources and strengths that a person has. So it could be actually, this person is using a lot of substances, but they are coming to their appointments at the drug service. They are still engaging. They are showing that they want to do some engagement. That's really positive. So how can we help build on that as part of the management plan? And do they have a particular key worker they really like that they can call when they're feeling suicidal? Thinking about crisis services as well, if that's something that they need. So considering all the things that someone might need and tailoring that risk management plan to the person, and collaboratively producing it, as I said. Sometimes just talking about the risks is a good form of risk management. So research has shown this regarding suicide and attempts to kill when someone attempts to take their lives. It can actually help to talk about it. So, and again, in substance misuse, someone might actually not be aware that drinking alcohol and taking heroin together is a really bad idea. They may not have any concept of that. So it could just be that they stop using the alcohol, for example, which reduces that risk. Let's look at a risk management example from the substance misuse one. So we've got the same case example as before. Management around the risks to self. A lot of this is education. So education around the risk of mixing substances, risk of accidental, and going through the risks. Then there's signposting to local, council housing, homelessness charities, support networks, soup kitchens, places where people can get clothing and bedding and food. signposting to the welfare system. Some people won't be receiving any benefits. Some people won't have a GP. It's all those sorts of things that are so important and basic, that we think are quite basic, but actually for people that are outside of that system, it's very hard. Then creating a safety plan regarding suicide and deliberate self-harm. Who can they talk to? How will they contact them? Where can they go? What can they do instead? These are all really important things, and having a written down, agreed plan is really helpful, particularly because if in this situation, this chap might be completely off his head and not be able to remember any of the stuff you talked about. But having that little card with the plan might just prompt them to go, oh, I need to ring Dave because that's the person that I said I would ring when I feel this way. We also would like people to have an assessment of physical health by medical professionals, GP, nursing, and treatment scheduled if they need them. Signposting to support groups and signposting to Narcotics Anonymous, Cocaine Anonymous, Alcohol Anonymous. Utilisation of support networks, so it could be religious groups, could be friends, family, professional support. And then also identifying goals and assessing motivation, because it might just feel, for people, they might just feel like they cannot find a way out, they can't do it. And that is a risk in itself. Someone feels they can't do something, that heightens risk. So actually helping people understand some of their motivations and what they want to achieve can help reduce risk. Management of the risks from others. Then we're signposting to the police for support. For example, in cases of cuckooing, where usually some sort of drugs-related gang will take charge of someone's council housing or owned housing to do what they want to do in there, usually a vulnerable person. Identify a safe location or locations for people to go when they feel this way. You know, if they're being attacked by people, then where can they go? Assessing safeguarding risks and sharing with safeguarding professionals, always massive. You know, if you're concerned about that somebody is in danger, you need to share that risk. Also risk to others in terms of management, again, signposting to the police, creating a safety plan. What can they do to avoid violence to others? What can they do instead? You know, if they feel that they're going to get angry and shout at someone or hit someone, then they need to run away, walk away, do whatever they need to do to get away from that. And again, sharing with safeguarding professionals. So this is an example of a risk management plan. Again, this may not be relevant to lots of settings that you work in. And always, the first thing you need to do always is speak to a supervisor. If you're in a pre-training, pre-qualified role, absolutely always speak to a supervisor. Even in a qualified role, my plan when I become qualified is to definitely pass that, run that past somebody once I've managed the risk in the way that I see fit. But it's very important that we share risk. We're not holding onto that risk. Even if it's just sharing it with the team, just saying, by the way, this has happened, just so everyone's aware. So yeah, sharing, that should be really part of the risk management, is sharing the risk. Just want to think about a mental health risk assessment example, because I am aware substance misuse is quite a, it's one aspect of what we do perhaps, but it's not very common. So here's another case example, again, not a real case. We have a trans female, aged 60, accessing a talking therapy service for anxiety and depression. In terms of risk to self, we've got psychological distress, we've got suicidal ideation, risk of deliberate self-harm. There is some physical health issues in terms of they have a long-term condition. Risk from others, there is a risk of violence as a trans woman. And there is a risk of social isolation and loneliness as well. And it could be that age group may not understand their gender identity and may struggle to relate in some way. There were no risks to others noted in this case. In terms of severity, the consequences could be fatal or very severe. In terms of suicidal ideation could get worse, deliberate self-harm could start. And there is an impact on physical and mental health as well. But actually, there are no active suicide plans. There are no plans for deliberate self-harm. There are no means to do those things because there is no plan. In terms of likelihood, there's no active suicidal plans or plans for deliberate self-harm, but they are likely to be very distressed. So actually, I'd probably class this as a fairly low-risk example. Even though risks are present, risks are always going to be present. And in terms of risk management for this case, what we'll be really thinking about is making sure that they Understand, you have a bit of a safety plan. So if someone does feel that way, if they do notice some suicidal ideation come in, where are they going to go? Who are they going to talk to? Documenting all of that risk and sharing some of that risk as well with the team. In terms of confidentiality and risk, confidentiality is really important. Obviously, we are working in therapeutic roles and we do have confidentiality. So we absolutely wouldn't share anything about anybody that we're working with friends or family, but we will share it with the team to make sure that we're managing risk appropriately. Sharing risk can sometimes involve breaching confidentiality. So it might be, I've had this case, I've had cases similar where a client's told me something and I go, oh, that does worry me. I'm going to have to check with my supervisor and just see what, just going to share that risk so I'm not holding it all. Then you go and tell the supervisor and they say, oh, yeah, you've got to refer to social care. And I can't get hold of the person, so I need to do that referral anyway because there is a risk there. So sometimes you will breach confidentiality, but it's important that you try and speak to the client first if you can, if risk permits it. Sometimes it doesn't. And you've got good justification for that, and usually that you've shared that with somebody to help make that decision. Yeah, so when you do this, you must tell the client, whether it's before or after. You need to say what your concerns are about the risks, what information you're going to share, with whom, how and when, what might happen afterwards, whether it's a social care assessment, police involvement. Ask them if they have any concerns or any information they want passed on. How do they feel about the risk? And yes, there is a risk that this can damage a therapeutic relationship. But safety comes above absolutely everything else. Contracting at the start of your work can help with this, and informing clients of when you're legally required to breach confidentiality also helps, and what will happen to the information you share. Reminding clients of your contract and kind of the confidentiality side of things is very important and useful as well. So how does this apply to me? Well, as a health professional, you have a responsibility to assess and manage risks. Clinically, that can look like risk assessments and safety plans, discussions about risk in team meetings and formulations. You'll be documenting risk on the case notes and records. You'll be developing skills to risk assess and manage when you're a qualified psychologist. And also job interviews. They ask about risk quite a lot. It could be, tell us about time you've assessed and managed a risk, well or badly, and what did you learn from it? It could be a client discloses something concerning to you. What do you do? All those sorts of things are very, very important. So there are lots of reasons that risk applies to us, but ultimately it's because we have a responsibility. Whether you're qualified or not, you have a responsibility. Clinical responsibility is slightly different. So if you're pre-training, pre-qualified, your clinical responsibility will lie in the supervisor rather than with us, because we won't be qualified to make those calls. So, but still, you have a responsibility to make sure that all risks are passed on. I did have some questions from you, so here we go, all about risk. What to do if somebody is actively suicidal? So as I said at the start, it's really, really important that you tell your supervisor that somebody is actively suicidal. You do that at the earliest opportunity, as soon as you can. And that doesn't mean hanging up the call or going, I'm just going to leave you because you told me you're suicidal. It does involve also, telling them that you're listening and finding out information. So you need to find out where they are if you're on the phone, who's around them, find out what their plan is. Have they got a specific plan or are they really distressed? Sometimes there can be a difference. And also, how impulsive are they? What in their history tells us whether they're impulsive or not? Because if they don't have a plan, they're feeling really distressed, but they're very, very impulsive, well, actually, that is quite serious. Have they taken any substances? Have they harmed themselves? How? Do they need medical attention? Do they have a safety plan? Inform them that you want to get some help, if it's 909 or GP or your supervisor. And inform them that you want to make sure that you're helping them as best you can by talking to your supervisor or somebody else who can advise. You're not doing it to get them into trouble or to embarrass them. You're doing it because you want to make sure they're safe. And document everything on the case record, in notes, however you document it, and on a risk assessment if you do. Yeah, update the risk assessment and key members of the MDT if required. But always talk to a supervisor. How do you mitigate risks? So, full risk assessment helps. Good understanding of the risks is like a really key foundation. You can't really manage risks unless you understand them. Knowledge of the client, very helpful. and taking each risk one by one or clustering risks together to address them. So you can look at suicidal ideation, deliberate self-harm, things like that, or you could look at mental health risks. Considering the likelihood means intent and severity. Asking for support if you are not sure. If you are worried about something, there is a risk, just tell your supervisor. They're never going to be upset with you for saying, I'm a bit concerned about this. It's part of our journey to developing our skills is to notice risk and know how to manage it and share the risk. Talk to supervisors, colleagues, the client themselves, or the people around them. And here we are with some resources. So there are some risk assessment tools, usually from forensic psychology. Here are some that kind of work quite well. And there are also these documents that I'll make sure that I link down in the description if you're interested at having a look at some of those risk assessment and management things. Thank you so much for watching. I hope this was a useful video all about risk assessment, particularly in clinical psychology. If you have any concerns about anyone that you're working with that's at risk, or yourself or anyone you know, make sure you share that risk with a supervisor or with somebody that's qualified, and make sure you do that as soon as you can. Thank you so much for watching, and I'll see you next time. Bye-bye.